maternal and child health impacts of state-level pregnancy-specific alcohol and drug policies and state-level abortion policies, and understanding of birthing people's use of alcohol and drugs. She has published more than 100 peer-reviewed manuscripts and has received grant funding from private foundations, the NIH, and other government agencies. She received her undergraduate degree in history from Columbia University, an MPH and a graduate certificate in women's studies from the University of Michigan, and a DrPH from the University of California, Berkeley. Welcome, Sarah.
Thank you so much for having me. Make this work. So, am I echoing a lot? Yes. Did I start and then we'll figure it out, or what do you want me to do? Oh, is that a little better if I move over here? Yeah. Awesome. Weird. Okay. No, I'm still echoing a lot. Yeah.
Is this better?
No. Oh, it's here.
Penn State and San Jose State. And we have a range of different disciplines. This is a truly transdisciplinary or multidisciplinary group. Public health, biostatistics, nursing, economics, political science, law, economics, computer science, physician, and social welfare. So it's a huge project. And I'll bring this theme back later on during the talk. I'm just going to keep going. Great. Okay. So I'm going to bring this theme back. I think that part of this story is about what it takes in terms of a transdisciplinary team, and we're looking at team science in order to pull off a project like this. So I'm going to start just by saying that alcohol is a known teratogen that causes fetal alcohol syndrome and a range of other harms to fetuses. Alcohol use in pregnancy is quite common. About 15% of pregnant women reporting any alcohol use in the past month, and almost 3% reporting binge drinking in the past month. What's also common are policies adopted in response to pregnant people's alcohol use. So you can see here, this is from some analyses that we did prior to launching this body of work, looking at trends in some of the pregnancy-specific alcohol policies that are in place in the United States. Not me.
I think you just press OK. But how do we get to OK?
I think it's whoever is through past the header. What if you could have things? What's that? I'm gonna keep going. Okay, so despite the fact that there are lots of policies related to pregnant people's alcohol use, so policies that single this out, rates of use stayed pretty flat. And so we had a question, what's going on in terms of these policies? What are the effects that they have? Are there any positive benefits? And are there any adverse consequences? And so we applied for an NIH 501 and we received it. And I'm going to tell you about the first phase of the project first, and then I'll tell you about the renewal that we've done since then. So for the first phase of the project was, we want to know, do state level pregnancy specific policies reduce harms related to pregnant people's alcohol consumption? The method that we used was legal epidemiology. At the most basic, the way to think about legal epidemiology is instead of looking at individual behaviors or medication use, for example, as the cause of adverse health outcomes, what we're doing is we are looking at laws. I typically look at state level laws, and so we're looking at laws as the cause of health and well-being. And then there's specific methodological components to it. One of the most important things to remember when you're thinking about legal epidemiology is it's really, really important to have good policy data. So you want to make sure that your exposure is measured accurately. And there's a whole method to coding these policies to be able to use in social science research. It's called policy surveillance. And I'll tell you a little bit more about it as we go along. So the research questions that we had for the first phase were, what are the relationships between state level pregnancy specific alcohol policies and pregnant people's alcohol use, prenatal care utilization, and birth outcomes? And the reason that we looked at prenatal care utilization is that one of the possible mechanisms through which we might expect these policies to maybe not contribute to improved health is that if you're scaring people too much, they're going to avoid care. So as I mentioned, the component of this is actually coding the policies using policy surveillance methods. And my colleagues at Pacific Institute for Research and Evaluation did that work. So probably the best way to describe what they're trying to do is you have an enormous data set of all of the laws for decades across 50 states, and you need to code them consistently so that you have variables, all like zeros and ones typically, from all of that qualitative data. So there's a lot of time in gathering the data, and then people are coming with the code book, they're applying the codes, they are noting where there's dual coding for all of them. There's meetings to discuss the discrepancies, and then there's checking those against other external sources. So the policies that we looked at are those that were tracked and have been tracked in the Alcohol Policy Information System, which is a system that NIAAA funds, and there's a contract with groups to keep updating it. And these are the pregnancy-specific alcohol policies that were included. So those that are in blue are those that we typically, historically, have thought of as probably supportive. And those in yellow are those that are thought of as more punitive. And so things like mandatory warning signs are the things that we see all over the place. Warning about possible harms of drinking during pregnancy. So now start to exist for cannabis. Priority treatment essentially means that pregnant people go to the front of the line in terms of entering substance use disorder treatment. These prohibitions against criminal prosecution really just apply to whether results of medical tests can be used in criminal prosecutions. There's a range of different reporting requirements for data purposes, for assessment and treatment purposes, for child welfare purposes. There's laws that define use during pregnancy as child abuse and neglect. And then there's laws that allow for civil pregnant people who are using alcohol. So just from a broad stroke, I'm going to share this with you, and then hopefully by the end of this presentation, you will also come away with the fact that this is not actually a useful distinction from a public health perspective. But when we started this work, this was huge. This was how everybody talked about both these policies and the policies related to people drug use. So supportive policies seek to provide information, early intervention, and treatment or services to pregnant people, and more punitive policies seek to control pregnant people's behavior by civilly committing them, mandating reporting to law enforcement or child welfare agencies, initiating child welfare proceedings, or using the threat of such actions to compel behavior change. As I mentioned, these policies are common, and this shows you the number of states that had these policies in 2022. So more than half, or roughly half of the states have mandatory warning signs, the different reporting policies, requirements, and child abuse and neglect policies, and then fewer states have the other policies. Here's just a graph that shows you the trends over time. This is based on the coding that my colleagues Sue Thomas and Ryan Peppers from Hire did. They took the data that was already available in the APIS from 2003 to 2013 and went backwards in time to 1973. And the first state to adopt one of these policies was actually Massachusetts, and it was a child abuse and neglect policy in 1974. And you can see that these policies have dramatically increased. And for those of you who are paying attention to the historical moments, a lot of them were adopted during the crack baby scare in the 90s and the war on drugs. And I'm not going to present these data here, but through sort of the mid-20 teens, other than for mandatory warning signs, almost all of these policies covered both alcohol and drugs. So the historical context of the policies related to alcohol and pregnancy also come out of the war on drugs. So we use legal epidemiology methods. The analysis methods that I'm going to present to you here are how we've started to describe them as more epidemiologic analysis methods, where we're looking at multiple policies in the same model. We're starting to do some more econometric difference and difference in synthetic control analyses, where we're trying to isolate the effects of single policies, but that's not what I can share with you today. So we've used more than 40 years of pregnancy-specific policy surveillance, 30 years of alcohol use during pregnancy survey data from Berkeley, and then 40 years of birth outcomes data from vital statistics records. So part of the complexity of this project is we have a pretty clear exposure, and our outcomes we're measuring through a variety of different databases. So every time I introduce a new outcome data source, I'll describe it and the analysis methods we used for that. And then I'm not going to repeat it when I come back to it. So just know that things show up and then they go away and then they show up again. So this is data from the behavioral risk factor surveillance system. There were about 57,000 pregnant women between 1985 and 2016 in the data set. The outcomes we looked at were past month any alcohol use, past month binge drinking, past month what we define as heavy drinking, which outside of pregnancy is considered heavy drinking, but it's about 4 drinks a week, which is the threshold at which the evidence is pretty clear that we observe this. And then we linked the Berkeley data to the policy data on state and year, used multivariable logistic regression with fixed effects for state and year, weighting to account for the complex sample and clustering of standard errors by state. And then we controlled for a whole bunch of individual and state level covariates. So what we found was that most of the pregnancy-specific policies were not associated with alcohol use during pregnancy, and those that were associated in opposite directions. So priority treatment was associated with more self-reported drinking, and then both mandatory warning signs and child abuse and neglect were associated with less self-reported drinking. And I emphasize this self-reported here, in part because, right, the mechanism that we think might be at play with both mandatory warning signs and child abuse and neglect is that people might be worried they're going to get in trouble. And so if we see less self-reported drinking, it's really hard to know whether that's a result of the policy causing people to drink less, or whether it's just that people are less willing to report when they worry that they're going to get in trouble. So I'm really glad we did those analyses. That's not where I think the end of the story is, as I'll tell you for the rest of the talk. So these are just the odds ratios for people who are interested in seeing magnitudes of effects. I've tried to be consistent with use of green to indicate a statistically significant effect that was in the direction we would want to see, and red when it's in the opposite direction. It'll be pretty straightforward when we're looking at pregnancy-specific policies, but when we look at the general population alcohol policies, it's a little more complicated for a variety of reasons I'll get to when we get there. So the next step is we looked at birth outcomes, so low birth weight and prenatal care use and preterm birth. And we used vital statistics records beginning in 1972. These included about 150 million singleton births. If you were born in the United States after, I can't remember if it's 1980 or 1984, you are in this, and you are for a singleton, you are in this data set. And if you were born in the 1970s, there's a 50% chance that you're in this data set. So it's a humongous data set. The outcomes we looked at were the birth weight, preterm birth, APGAR score, prenatal care, and we linked the vital statistics data to the policy data on the state and then the month and year of conception. So we treated the policies in effect if it was in effect for somebody's entire pregnancy. Analyses were the same as with the birth data, but we added state-specific time trends to the models. So what we found was that half of pregnancy-specific alcohol policies led to increases in low birth weight and preterm birth. And low birth weight and preterm birth were higher when any of the following were in effect: mandatory warning signs, priority treatment for pregnant women, prohibitions on criminal prosecution, and child abuse and neglect. Here are the odds ratios. You can see that the effect is small. The odds ratios are like 1.07, for example, but they're all pretty consistent and in the same direction. So in terms of, and I have the slide in here, so I'll say it now, and then if we see the slide in a moment, so again, we can look at it. But we look to see how many babies that translates into each year. So we used 2015 data. And we estimated that in 2015 alone, there were thousands of babies who were born low birth weight or preterm birth related to these policies being in effect. So depending on the policy, it was between 2,000 and 12,000 babies each year. So we looked at prenatal care use as well. So 3 of the pregnancy-specific policies were associated with decreased prenatal care use and 1 with increased prenatal care use. So mandatory warning signs, child abuse and neglect, and civil commitment were associated with less prenatal care use. So again, more support for this hypothesis about fear contributing to people avoiding care. And then 1 of the priority treatment policies was associated with more prenatal care use. And here are the odds ratios. Oh, and here is the graph that I promised that you are interested in. Great, so just to name a few of the strengths and limitations, we have incredibly rigorously coded policy data. We have vital statistics, outcome data that do not rely on self-report. Some notable limitations are that willingness to report on purpose could be influenced by the state policies we studied. The vital statistics data are not collected for research purposes. And so there were some individual level variables that we wanted to look at that we couldn't. There was measurement of key variables changed over time, but we did include fixed effects that should address that. So to try and summarize this part of the work, just to go back to the big picture, do pregnancy-specific alcohol policies lead to reductions in alcohol use during pregnancy? Maybe slightly is from where I land on that. I don't know, based on what we did. Do pregnancy-specific alcohol policies improve birth outcomes? No, they actually seem to increase adverse birth outcomes. And do they lead to increases in healthcare utilization? Actually, no, they seem to contribute to decreases in healthcare utilization. So what I hope to make pretty clear is that I think that this punitive versus supportive distinction is not actually that helpful. I think it is useful for people when they're thinking about it from more of a political or a legal aspect or even ethical aspect, but from a public health evidence perspective, it's not really relevant. So at best, most pregnancy-specific alcohol policies do not affect use during pregnancy, birth outcomes, or prenatal care use. And at worst, some of them seem to increase adverse outcomes. And so what this led to in terms of a paradigm that I use in terms of my work and that I hope to pass on here today is that when we think about harms related to alcohol use during pregnancy or in relation to drug use during pregnancy, we tend to focus on the harms related to the substance itself. There's also harms related to the healthcare practices and policies that we adopt in response. And as researchers and healthcare providers, I think it's really important to to remember that and to be aware of that, to be really, really, really careful before making any broad recommendations about that. And what I would say is that we really need some new policy approaches related to reducing harms related to alcohol use during pregnancy. So as I was finishing that phase of the work, people kept asking me, well, what should we do? Please tell us. Should we just, get rid of all these policies? And at that point, I wasn't quite sure that I was fully ready to make that recommendation based on that evidence. There's ethical reasons why it would be good to get rid of some of those policies, but from an evidence perspective, it seemed like we needed to do a little bit more investigation to see whether there are any possible benefits to these policies. And so we had a phase 2 of the project where we proposed to look at other outcomes related to these policies and then take a step back and ask the question that people had actually suggested almost 40 years ago. Maybe some of these general population alcohol policies like taxation and restricting where and when alcohol can be sold, what if those might make a difference? So the next part of my talk is going to focus on further investigation of the pregnancy-specific policies with additional outcomes, and then on the general population policies. So here we looked at the relationships between state-level pregnancy-specific alcohol policies and substance use disorder treatment during pregnancy, infant morbidities and related to maternal alcohol use and infant maltreatment, and then severe maternal morbidities. For the substance use disorder treatment, we used TEDS-A, which is the treatment admissions data set. It's an administrative data set. We had more than 500,000 women who were pregnant at the time of admission, who reported alcohol as a primary substance or any substance over more than 1,000 state year combinations. So these are all at the aggregate level between 1992 and 2019. The outcomes were treatment admissions, and we linked the admissions to the policy data on state and year. And then we used Poisson regression models with an offset variable, the natural log of the number of pregnancies in the state and year. And other than that, analyses were pretty similar. So 2 pregnancy-specific alcohol policies were associated with increases in treatment admissions during pregnancy. That was civil commitment, and these reporting requirements for assessment and treatment. And reporting requirements for assessment and treatment can often use the threat of further child welfare involvement to encourage people to enter treatment. So each of these are using the potential either for incarceration or child welfare system involvement. And both of those relate to increases in treatment admissions during pregnancy. And then when we looked at the secondary outcome of alcohol being any substance and not the primary substance, 2 additional policies were associated mandatory warning signs and priority treatment for pregnant women. But those were in the opposite direction of what you would want. And I think what's really important to note here is that you would assume that priority treatment, right? The purpose of priority treatment is to help more pregnant people get into treatment. And we're not seeing evidence of that happening. So So this next part is using claims data. Right now, we started by using private insurance claims data from the Meredith Market Scan database. We're now working on creating a cohort tool to do these same analyses using people whose insurance is Medicaid. So we included 1.4 million singleton births between 2006 and 2019 among birthing people 25 to 50. And we excluded the younger people because we couldn't match them with babies. Because what we learned afterwards, even if we can't confirm it, is that people over 25 who are giving birth are often on their parents' insurance, but then the baby can't be on that insurance. So in the data set, you can't link them. So the cohort included those who were enrolled for a year before and 1 year after delivery and could be matched with an infant who had a claim within the first month after they gave birth. Our outcomes were infant morbidities associated with maternal alcohol consumption, infant injuries consistent with maltreatment, and severe maternal morbidities based on, and we used ICD-9 and ICD-10 codes. We linked to the policy data based on state and then month and year of conception. And analyses were similar to what I've shared before. So 4 of the policies were not associated with either the infant or maternal outcomes. 2 of the policies were associated with increased adverse infant and maternal outcomes without being offset by a decrease in another outcome. So both mandatory warning signs and reporting requirements for assessment and treatment. 2 policies were associated with improvement in one outcome, but were offset by associations with worsening of another outcome. And then 1 policy was associated with improvement in one outcome. So what you can see here is that other than for the priority treatment policy, everything is either red across the way or there's red and green. So there really isn't anything here that looks like these policies are doing what we want across the board. So again, rigorously coded policy data is a strength. The claims and treatment outcome data sets do not rely on self-report. Again, data not collected for research purposes. Outcomes are based on ICD and diagnosis codes, not actual measurement of the outcomes. They're private insurance claims we can't generalize to people with public insurance. And we have exclusion of people younger than 25, means we don't know what's going on with them. And then we have changes from ICD-9 to ICD-10, which wants to talk methods. I'm happy to talk about how we navigated that. So I feel much more confident at this point in making some conclusions about these pregnancy-specific policies. So most pregnancy-specific alcohol policies were not associated with decreased infant injuries or morbidities or maternal morbidities, and were sometimes associated with increased odds of at least one adverse infant or maternal outcome. And policymakers really should not assume that the pregnancy-specific alcohol policies reduce harm related to pregnant people's alcohol consumption. Should be really, really cautious about adopting any new ones. And I think we're probably also getting close to saying there's some that they should probably start repealing. And then I would say, actually the other thing I would say is, I didn't share the prevalences of some of the outcomes, but what we found for the infant morbidities, I might the numbers might be flipped from this, but one of them was 2.1%, the other was 3.1%. In terms of the infant morbidities related to maternal alcohol consumption, and then the infant injuries consistent with maltreatment. So it's not that there isn't a problem that needs to be addressed. And it's actually like, you know, when you're sitting there counting the number of babies who have these outcomes in these data sets, it's like even worse. You're just like, oh my gosh, we have all these policies that are in effect and they're not, like they're clearly not helping and they might be making this worse. And this is really getting in the way of us identifying solutions that might help address the problem. So often when I've given talks like this, people are like, but you're saying that it's okay for people to be drinking during pregnancy, we shouldn't be doing anything. And what I'm trying to say is actually what we need is something that's going to work, and what we're doing isn't working. People often also have some questions about mechanisms, and I'm happy to talk more about that. But some possible mechanisms are the fear of getting prenatal care or treatment will lead people to be reported to child welfare and have their children removed. Mandated treatment or coerced treatment in some way might get people into treatment, but there may be a rapid and increased return to use immediately afterwards. I think a huge one that we know from research that I've been doing related to warning signs and cannabis use during pregnancy is that pregnant people don't trust the information in the warning signs. And then there's also just not enough funding for treatment, even when priority is mandated. So we've been experimenting with different ways to try and synthesize these findings. And so this is our current experiment. And then we're going to work with a graphic designer to make this look prettier than my attempts like this. And we're also going to try and figure out how to incorporate some of the where we feel more confident based on our methods versus where there should be more caution. But hopefully what you can take from this is that there really isn't anything that has green across the board in terms of saying, yes, we should do this. And there's some policies that really seem to just be much more consistently associated with adverse outcomes. And then that might be a place to start dialing back. So just to go back to these overarching research questions, do pregnancy-specific alcohol policies lead to reductions in alcohol use during pregnancy? Maybe slightly. Say that again. Do they improve birth outcomes? No, they actually seem to lead to increases in adverse birth outcomes. Do they lead to increases in healthcare utilization? They actually seem to contribute to decreases in healthcare utilization. And then they're related to increases in treatment admissions. It doesn't translate to improved infant or maternal health outcomes. And then do they improve maternal and infant outcomes? Not really. They sometimes seem to increase those outcomes. And to the extent that there's any benefit, it seems to be offset by something getting worse. So these are essentially the same conclusions as the first time, but I would say just even stronger. And so I think really harms from alcohol use during pregnancy come from use and from the policies adopted in response. And we really need some alternative policy approaches and other approaches that might make a difference. So the next question is, might general population alcohol policies be an alternative approach to reduce harms related to pregnant people's drinking? So we are in much earlier phase of these analyses. I think 2 of them have maybe been published. And so this is in a much less synthesized fashion than what I just shared with you. And I will also say, this is part of the team science piece, I'm not an expert on these policies in a way that I am on the pregnancy specific ones. And so I've really been relying on an amazing team of people who are experts in them. So if I can't answer one of your questions about exactly what one of these policies does, I'm happy to get you an answer. But just naming that is a commitment, an amazing component of the project. So we are looking at the relationships between state general population alcohol policies and alcohol use among women of reproductive age. The idea is that people don't start drinking when they become pregnant. To the extent people are drinking when they're pregnant, they were typically drinking before they became pregnant. So understanding the relationship between policies and drinking among people of reproductive age is one way to think about looking at. And we also have better data to look at that than drinking among pregnant people. Looking at adverse birth outcomes, substance use disorder treatment, the same infant outcomes, and severe maternal morbidities. We are looking at all of these different alcohol policies. We're looking at some minimum legal drinking age policies. That work is in process. But we've also been looking at blood alcohol concentration policies, government monopoly control over retail and spirits sales, where alcohol can be sold and the different types of alcohol that can be sold at gas stations and grocery stores, the store hours where you can buy alcohol, and then different beverage specific taxes. So here's some trends in the general population alcohol policies. And I think a few things that are important to note about this. There's a lot less fluctuation here than there is in relation to the pregnancy specific policies. The policies that I would say are more criminal justice oriented, like blood alcohol concentration policies, are getting stricter. And those that relate to really restricting alcohol availability are getting weaker. And then from a methods standpoint, there's not that many policy changes, and they tend to flatten out over time, and that just makes the modeling much more difficult, and it also means we have to be much more cautious in our interpretations. So I'm going to introduce a new data source, the National Alcohol Survey, which is a survey that the Alcohol Research Group has been doing every 5 years, I think since the 1970s. The sample that we are looking at here includes more than 13,000 women of reproductive age participating in the survey between 1984 and 2020. The outcomes are the number of drinks, the number of days where people drank more than 5 drinks, more than 8 drinks. And then we put the survey that follows the data on state and year. And we use negative binomial regressions. These analyses are a bit different because it's a survey and a much smaller sample. We couldn't include the same kind of fixed effects for state and year or the state specific time trends. So we have much better alcohol measurement than we did elsewhere. So in terms of just summarizing some of the findings, allowing heavy beer sales in gas stations and Sunday sales, so making alcohol more available, was associated with increased drinking among women of reproductive age, and then a government monopoly on retail spirits sales and lower blood alcohol concentration limits were associated with decreased drinking among women of reproductive age. So this is exactly what we would expect, right? Which is good to see that always when you do analyses like this. Here are the regression output. And this is where things are not quite as polished as the earlier phase. The way we've done this is everybody on the team does their own analyses and then writes their own papers. And turns out that people are using the policies in different directions as they were conceptualizing them. So I apologize. I only caught this when I was putting it together and there wasn't time for rerun everything. So I've tried to emphasize the directions that things are in and use red and green to signal what's going on. But just, these are spirits, things being allowed in different settings, and then others will be prohibited. So just naming that and taking a moment to realize how complicated this is to make happen. In terms of looking at birth outcomes, you are the first group to see this information. These analyses are just done as of last week. So 3 of the policies were not associated with birth outcomes. Prohibiting heavy beer sales in grocery stores and spirit sales in gas stations was associated with increased adverse birth outcomes, which is a bit surprising. But in consistent with the direction we would want to see, prohibiting heavy beer sales in gas stations and then having government monopoly control of retail liquor sales or spirit sales was associated with decreased adverse birth outcomes. So here's the regressions. In terms of findings for infant and maternal outcomes, 2 of the policies were not associated with infant outcomes. So spirit sales in gas stations was associated with increased infant morbidities and maltreatment. Spirit sales after 10 p.m. was associated with decreased infant morbidities, but increased infant maltreatment, which actually increased infant maltreatment makes sense to me. And then government monopoly control on retail spirit sales was associated with decreased infant morbidities and maltreatment. So just to name this in case you're very listening, like I think there might be a pattern. Government monopoly control. So having to buy liquor only in government run stores is the policy that seems to be the most protective across the board. Unfortunately, it is a policy, the only changes in that policy are going in the opposite direction to move towards privatization. But this should maybe caution people to not do that. Here's the regression output. And I would be remiss to say, so there was no policy change in gas stations during the time period for this analysis. So this is just based on cross-sectional analysis, and there's no within state change, so just be cautious about that interpretation. I put this last in part because we're still wrapping our brains around how to interpret it. For the pregnancy-specific policies, it seemed pretty clear that what we were looking at was an increase in treatment was good and a decrease in treatment was bad. For the general population policies, it could, I can't quite wrap my brain around it, because you could see an increase in treatment because more people need treatment, or you could see an increase in treatment because more people who need treatment get treatment. So we're still trying to figure out how to interpret these. But most of the general population policies were not associated with treatment. Admissions among pregnant people related to alcohol. Allowing heavy beer sales, but not spirit sales in grocery stores was associated with decreased treatment, and then lower blood alcohol concentration limits was associated with increased treatment. That one makes sense to me. That if you're getting punished, you might be more likely to their treatment. And that's consistent with the pregnancy-specific policies. So here is a synthesis. On this one, you see much more green, which is nice. So both lower blood alcohol concentration limits and government monopoly, and then prohibiting heavy beer sales in gas stations were associated with decreases in adverse outcomes. And then others were a bit more mixed in terms of what we saw. But this gives me a little bit of hope. But at least there's something that maybe could happen. So now I'm going to share the findings about taxes. And we've looked at those separately for a variety of reasons. But one of the main ones is that we only have the tax data for states where there are not government monopolies. It's only for places where it's privatized. And so we have a smaller subset of states. And we looked at 3 different types of taxes, ad valorem, volume-based taxes, and then whether there's a sales tax for off-premise sales. And you can again see here there really isn't that much fluctuation in these policies. So just want to name that as we get started. So in terms of what we found for the taxes, only one beverage-specific tax was associated with drinking among women of reproductive age, and one beverage-specific tax was associated with substance use disorder treatment. None of the taxes were associated with infant maltreatment. One beer tax was associated with increased infant morbidities, but on a more promising note. 2 wine and 2 spirits taxes, both volume-based and sales taxes, were associated with decreased infant and maternal, adverse infant and maternal and infant outcomes. So you can see here is pretty much nothing among women of reproductive age. And pretty much nothing in terms of substance use disorder treatment. And here you can see that both the wine volume-based and wine sales tax and spirits volume-based and spirit sales tax related to decreased adverse outcomes. So this just shows you this again, but just focusing on the taxes. So again, we rigorously coded policy data, long time series with continuous alcohol consumption measurement. The claims and treatment outcomes don't rely on self-report. We're going to work on birth outcomes next for the taxes. We weren't able to include fixed effects for state in the National Alcohol Survey data. Some data were collected for research purposes and some were not, which limits what we can include in models. Again, outcomes, the same limitations in these data as before. So policies that allow alcohol to be more available generally seem to relate to increased drinking among women of reproductive age and increased infant outcomes. Lower BAC limits relate to decreased drinking among women of reproductive age and increased substance use disorder treatment among pregnant women. And some alcohol taxes, specifically related to wine and spirits, seem to relate to improved infant and maternal outcomes. So harms from alcohol use during pregnancy come from use itself and from the policies adopted in response. Let's say the pregnancy-specific policies are ineffective and in some cases actually harmful to pregnant and birthing people and infants. And general population alcohol policies might be a more promising approach to reduce harms related to pregnant people's drinking. The specific research that I talked about today has been funded by NIAAA RI1, but there's been so many funders that have contributed along the way to this entire body of work, including March of Dimes, Contra Costa First 5, California Department of Cannabis Control, and some UCSF funding. So I will stop there.
I have a question about the Sunday, being able to buy alcohol on Sundays. Have you looked at states where they have changed that law? Because in Colorado, I had to Google it, but in 2008 is when you were able to start purchasing alcohol on Sundays. And so I wonder if people in states where liquor stores are not open on Sundays just don't drink as much, because I recently watched the talk and there was a lot lower binge drinking rates in the South compared to like the rest of the US, and that might be where it's not open on Sundays.
Yeah, so again, I'm not an expert on these general population policies. One of our next steps is trying to isolate some specific policy changes that we can look at. It's actually amazingly difficult to do that because you need to identify a policy change that didn't co-occur with another policy change, and where you have a policy change that occurred in like the 2 years before or the 2 years after, or that didn't happen at like a moment where the birth certificate data changed, or the ICD-9 to ICD-10 changed. And so there's not that many policy changes, especially when we have data sets that only go from 2006 to 2009. So I would love to look at these specific policy changes in terms of the Sunday sales piece. I think my understanding, and I could be wrong because this isn't my content area, I don't think that the banning of Sunday sales or allowing Sunday sales is one of the policies that's recommended by the WHO. So WHO, in terms of effective alcohol policies, really recommends increase in pricing and then sort of decrease in physical availability. So having alcohol less physically available is really important. So reducing alcohol outlet density, for example. And then government monopoly control. So having less privatized sales is recommended, but usually the Sunday sales doesn't count.
Yeah, I thought it was interesting, and I only know this from living in Colorado. I wouldn't know any other state.
I mean, I grew up in New Jersey, and I remember in New Jersey when I was growing up, you could only buy like even beer and wine. You had to go into a specific liquor store. You couldn't get it at the grocery store. I remember moving to California, and there was like, you know, I mean, there were spirits like in the CVS. And that's so bizarre. And it took me a while to.
And then, sorry, I'll let other people talk. They also recently just allowed you to buy wine in grocery stores in Colorado this past year, so that might be gabbing.
So the tricky thing with some of these is that those policy changes, they often co-occur with other policy changes, and wine tends to not be a policy change that happens on its own. You'll see the change happen either wine and beer or like wine and spirits. So it's really hard to look at the wine related policy changes. Yeah. I don't know if I'm good.
You mentioned WHO, so I'm just curious if you or others have made any comparisons with other countries, their policies, and the effect of their policies on the topics at hand, because there might be cultural aspects that are specific to this country that are at play, and I'm not sure they're captured in the way we can do it now.
Yeah, I mean, so the pregnancy specific policies, I think we are,
Don't we find like-
yeah. The way we've had an absence message related to alcohol use in pregnancy much longer than many other countries do, and our recommendations have always been stricter than many other English-speaking countries. And we tend to have more policies that mandate reporting. So yeah, I think it'd be great to look at other countries' policies related to alcohol and pregnancy and try and understand what's happening there. I think that'd be amazing. And there have been some policy changes with adopting warning signs recently, so it'd be great to do that in another context. I hope that the work on the general population policies and these outcomes inspires the international group of researchers who focus on alcohol policy more generally to start looking at the maternal and infant outcomes, because that isn't something that they've done. I mean, they've been doing that research for 30, 40 years at this point, and there's maybe 3 studies that have tried to look at the relationship between these general population policies and maternal and infant outcomes. Yeah. So, yeah, no, great question. I glossed over a lot of the technical details, so you didn't miss anything. You tried to exactly something. So what we did was we used a variable of where there was a systematic review that looked at the public predicted value of different ICD-9 and ICD-10 codes related to actual maltreatment. And we used those that had a positive predictive value of like 50% or greater. We wanted to use the one with, I don't know, 70 or 80%, but it was so minuscule. So we couldn't look at that. So we don't know who the perpetrator is. That information isn't in there. We don't 100% for sure know that it's actual maltreatment, but the injuries themselves are the way I like. I think it's like we like to avoid those injuries, like even if we don't know that they were caused by somebody maltreating.
Yeah, well, and the reason why I'm wondering is that I suspect that it's possible that some of the counterintuitive results maybe that it could be working on a pregnant person, but they're obese, but there could still be high levels of brain symptoms. And or I mean, because in general, pregnancy is the most dangerous time for a pregnant person, and that frequently in the postpartum period, it can be very dangerous for both them and their offspring if they're in. And so it could be, you know, something else to think about, especially if like they were code users and then the pregnant person stopped and there were then, you know, that led to taking it out.
I mean, 100% agree. I'm really glad you raised that. I think that's something that we need to figure out how to take into account in terms of the general population lens. In terms of the pregnancy specific ones, I'm a little bit less concerned about that. But for the general population lens, like absolutely 100% for the infant maltreatment lens. For the infant morbidities related, I mean, those are all birth defects related to maternal alcohol consumption. So I feel that one I feel pretty confident about, but the infant injuries one is definitely one where, yeah, we don't know whether that was the pregnant person who had been drinking or somebody else in the house. Fabulous. I'm just gonna go around the room. Go ahead.
Sorry, I'm curious, is there any data about pregnancy and nutrition? I just need to know these effects based on plan versus.
So this gets into, it's really, really, really hard to do surveys with large samples of pregnant people. So we wanted to do that. I just did another study where we wanted to look at relationship between living in a state with mandatory warning signs for cannabis and people's beliefs about the safety of cannabis use and whether they use cannabis. And we worked with one of these national survey firms, and the only way we could get anywhere close to our sample was including people who were currently pregnant or recently pregnant. So like, it's just really hard. And you then don't have enough of a sample and that you can't use the more complicated methods to then look, right, to break people down in terms of to break the groups into subgroups to be able to look at that. I think that the question as to whether people are more likely to reduce alcohol use or not during intended versus an unintended pregnancy. One of my colleagues is leading an amazing study design comparing, like, where you can actually look at that question, and we have a doctoral student who's gonna look at that. So share more information about that. Okay, going around the room.
Yeah, I was curious, in a similar sense, if the treatment to seek substance abuse disorder, whether it's government mandated as a part of a criminal case or whether it's voluntary, if that's somehow looked at within the data.
I think at some point we thought about, I think there's there might be a variable in the data set that looks at sort of the source of the referral to treatment among pregnant people. Like, it's almost, I mean, we didn't look at that here, but it's almost all referred by child welfare, right? I mean, it's not, or like a self-referral. I don't think that we have enough. I don't think the sample is quite big enough where we could actually look at that, but now that you're saying it, I mean, I wonder if we.
Specifically with the correlation between the lower BAC value and the increase in substance abuse treatment disorder. I mean, basically, the first thing that happens to somebody in front of the judge that's, you know, anything with alcohol or drugs is they get mandatory treatment imposed upon them, regardless of whether they're charged with anything. So a lower BAC then get a 0.2 and it will, you have to see a judge. Okay, no DUI for you, but you got to treatment.
Right, and I think that that's the explanation that seems the most plausible to me, given that the pregnancy-specific policies that were associated with increased treatment were also those that seem to be more related to mandatory treatment. Yeah. And I know there's huge debates about mandatory treatment, which is well, very good question.
Would you be able to speak briefly to any compounders that you included, like in terms of like the PA and other things that they have impacted, like female care?
Yeah, so the state level confounders that we included poverty, we included unemployment, we included per capita tobacco consumption. In the pregnancy specific models, we typically also included per capita alcohol consumption and some of the general population alcohol policies. And we've done a lot of sensitivity analyses, and I can't remember exactly what's included in each final model. And then we use a lot of individual level controls. In terms of something like the ACA, for the prenatal care utilization outcomes we looked at, we mostly stopped those analyses in 2013, so probably that didn't come into play, but also those that even extended. I think we didn't actually look beyond 2013, but for policy changes like that, the state, and my understanding is that the state and year fixed effects should actually do what you want, because it's going to be like either a 0 or 1 for that state and year, whether, you know, they had expanded Medicaid or specifically expanded Medicaid for pregnant people. And so that should be captured in the state and year fixed effects. Is my understanding. Yeah.
Thank you so much.
Right.